So the next session is on pancreatitis in pediatric population. May I call upon the chairpersons, Dr. Gautam Roy, Professor, Pediatric Gastroenterology, IPGMR Kolkata, Dr. Arun N, Senior Consultant, Pediatric Gastroenterology, Apollo Chennai, and Dr. Jayendra, Associate Professor, Department of Pediatric Gastroenterology, CMC Vellore.
So we'll start off, and on behalf of everybody, we congratulate Sudipto for such a wonderful meeting. Even though we are late, but we are learning, so let's not fret about that. So it is my pleasure to invite the first speaker, Arul. Arul Premanand is a long-time friend of mine. He is a professor in the Department of Pediatrics at CMC Vellore, and he heads the Pediatric Gastroenterology Unit. A wonderful person at heart. Arun.
Thank you, Gautam, for your introduction. So, today my talk is about chronic pancreatitis in children. And this is the overview for the next of my talk for the next few minutes. And I start with a case scenario. It's a 3-year-old boy who came to us with complaints of abdominal pain for 5 months, abdominal distension for 4 months, and poor weight gain for 3 months. And he has been treated as nephrotic syndrome elsewhere. So what we have noted is he was pale, he was looking pale, and there was an ascites. And initial investigation, other than anemia and hypoalbuminemia, we have noticed mildly elevated amylase and lipase. The ascitic fluid gives the clue. It was a low sag ascites with markedly elevated amylase and lipase, suggestive of a pancreatic ascites. So the imaging further diagnosed, and CT with MRCP showed features of acute and chronic pancreatitis with peripancreatic collection and atrophic pancreatic parenchyma with dilated irregular ducts. Suggestive of the final diagnosis was acute and chronic pancreatitis with pancreatic ascites. So coming to the definition of chronic pancreatitis in children, as per the INSPIRE criteria, the mandatory is imaging finding of CP, and remaining things like any one of these, like abdominal pain consistent with CP, or evidence of exocrine pancreatic insufficiency, or evidence of endocrine pancreatic insufficiency. And the imaging findings either could be a parenchymal changes or ductal changes. Etiology of CP in children is totally different from adults, where adults it's more of alcohol and biliary obstruction, but in children there are a variety of causes. However, genetics and structural causes plays a major role. Genetics, particularly SPINK1 mutation, PRSS mutation, and CFTR are more common. And structural, as far as structural obstruction is concerned, it's more of congenital anomalies in children like pancreatic divisum and Malunian and choledochal cyst. However, in adults, it's more of stricture or a tumor. And what we thought was earlier idiopathic, which have been labeled as idiopathic, may have a genetic background also. With the development in genetic testing, we can diagnose more and more genetic etiology for chronic pancreatitis. The clinical presentation, as in adults, it's more of abdominal pain, nausea, vomiting, and growth, poor growth, and other features of endocrine insufficiency as diabetes, or exocrine insufficiency like a steatorrhea, malabsorption, and weight loss. Evaluation of children with CP, this is the basic lab investigations, which should include, this is to look for the risk factors for the chronic pancreatitis. Say for example, if you find out hypertriglyceridemia that is being defined as more than 1000 milligram per deciliter, then they are prone for, there is a risk for developing pancreatitis in those children. Like that, hypercalcemia, if it's present, then you should look for the further evaluation for primary hyperparathyroidism or any parathyroid adenoma and others. If there is a LFT derangement, that will give us a clue whether there is a biliary obstruction. These are the basic lab investigation to look for the risk factors. Other than that, we have to look for exocrine pancreatic insufficiency by fecal elastase test. Normal is more than 200 milligram. If it's less than 200 milligram, it's suggestive of EPI. And what the test, 72-hour fecal fat collection test that we have done earlier days, we are not using that now because of the practical difficulties. Endocrine pancreatic insufficiency, otherwise called as pancreatogenic diabetes or a type 3 diabetes, was diagnosed based on the standard WHO criteria for diabetes mellitus. Once diabetes has been diagnosed, we should involve the pediatric endocrinology team for the further management, including insulin therapy or any other therapy. And children who have have no identified causes should go for a genetic sequencing. So the picture on the top showed a different type of genes that have been identified over the years. Nearly some 12 genes have been involved in chronic pancreatitis. And the table on the down, the picture on the down showed the INSPIRE data, where they showed that 75% of the children with CP will have a genetic mutation, particularly PRSS1, SPINK1 and CFTR are more common. So what is the distinct characteristics of this hereditary pancreatitis is the early onset, rapid progression, and risk of developing ductal stones, as well as risk of developing EPI and endocrine deficiency, and there is a chance of future cancer in these children. So this is the CMC data on genetic sequencing children with CP, where we are doing along with the endocrinology department. So far we have screened about 20 children. 60% of them have a 60% of the children with CP is having a genetic mutation. Among the genetic mutations, SPINK1 is the most common mutation that we are observing so far. So imaging plays a major role in chronic pancreatitis, and each imaging modality has its own merits and demerits. And the preferred imaging is a MRCP in children. CT can be used in acute situations to assess for the complications, as well as like a calcifications or a pseudocyst or walled-off necrosis. Our MRCP can visualize both parenchymal as well as the ductal changes in detail and can show like ductal irregularities and stones and strictures can be diagnosed. So as shown in this images, other than the diffuse parenchymal atrophy, ductal dilatations and irregularities are common in children, and also calcifications also are present in children, but not as common in adults. And other unique problem, as Dr. Nigel Thomas was talking about, tropical pancreatitis in children, particularly in tropical countries like India. It is characterized by the triad of abdominal pain, fibrocalculous pancreatic diabetes, and steatorrhea. So this image is showing a fibrous fatty replacement of the pancreatic parenchyma, and there is a ductal dilatation with studded with calculi. And this tropical pancreatitis is historically linked to the malnutrition and cassava consumption that was found in tapioca, but the exact cause has been now attributed to genetic reason, particularly SPINK1 mutation, along with environmental and dietary factors. So the management, particularly medical management, include pain management. So this has been beautifully explained by Dr. Singh. So it's a mechanism of pain is a complex, multifactorial as well as a progressive process. Both structural damage as well as the neuromodulation of the peripheral nervous system and central nervous system. Why we should know this mechanism? Because we can target the treatment. For example, if it's a nociceptive because of the tissue injury, we can give more of NSAIDs and opioids and local anesthetics. But if it's a neuropathic or neurogenic pain, then try to give more of pregabalin and gabapentins. If it's a central cause, antidepressant may be helpful. And this is the analgesic ladder that has been proposed by Naspagan. So this for a mild intermittent pain, you can use a level 1, which is a non-opioid medications like paracetamol and NSAIDs. But if it's a more of moderate persistent pain, then go to the weaker opioids like oral tramadols. And if there is a more consistent pain, then go for a potent oral opioids, and also needed to admit and do further IV opioids, and also to give patches. Malnutrition in children is multifactorial. However, pain and anorexia and malabsorption, fat malabsorption is the major cause, and we should aim for a healthy diet with 45 to 60% carbohydrates, 10 to 30% protein, 25 to 35% fat, and we should keep monitoring the growth and development of these children. And pancreatic enzyme replacement therapy, this is extrapolated from the cystic fibrosis treatment, and I am not going into the detail of the doses, as we know this. And coming to the another important interesting thing about antioxidants in children with chronic pancreatitis, the hypothesis is that there is an oxidative stress and there is a depletion of antioxidants that have a role in pathophysiology of CP. By giving antioxidant, we can prevent the prevent the progression of the CP, but there is no strong evidence for this hypothesis. However, the recent study done by SGBGI team, Dr. Anshu is here, and they have done this, and then they found that this antioxidant have a good response. That means what do you mean by good response is like more than 50% reduction in the pain. So that has been achieved with antioxidants. More than that, they also, the table looks little congested, but they also tested the oxidative stresses, and then they found that oxidative stresses have been reduced nicely, and it was statistically significant. So this is emphasizing the role of antioxidant in children with chronic pancreatitis. Psychological support is very important, and children or pain is a major factor for affecting the children's social life, and they are at risk of developing anxiety and depressive symptoms. So with the help of pediatric psychologist, we can plan for other therapies like cognitive behavioral therapy or coping up skills and other things. Parental support also is very important. Therapeutic interventions, EUS, ERCP and ESWL should be done by the expertise. That's mainly that as the expertise are here are adult gastroenterologists, and we are always happy to approach our adult gastroenterologists for these therapeutic interventions. And as per the NASPGHAN, EUS can be used both diagnostic as well as therapeutic, and EUS can diagnostic in microlithiasis or pancreatic anomalies, and therapeutic mostly in the cystogastrostomy of the pseudocyst. So here the images shows there is a pseudocyst, and the second image shows the stent in the pseudocyst. ERCP should not be used solely for the diagnostic purpose. It should be reserved for those children who may need endotherapy. So ERCP again is more useful for decompressing the ductal pressure, mainly for sphincterotomy and also for stone removal and stent placement. So this is the one study which studied the efficacy of the therapeutic ERCP in children with chronic pancreatitis. Mainly the stenting was done because for the pancreatic duct obstruction or suspicion of any anatomic malformation. What they found was a significant decrease in the number of pancreatic episodes per year from 1.75 to 0.23. Many of their patients are more than 8 years old, up to 18 years old. So this study emphasized the fact of like selecting the patients for ERCP and the benefit of the ERCP in those patients. And ESWL and this is ESWL is recommended in stones which are big, are not able to retrieve by endotherapy. And there is a specific indication, as Dr. Manu Dandan has specifically mentioned, about the symptomatic patients, that is painful chronic pancreatitis and the stone size more than 5 mm, then we should consider ESWL. So those pictures showing a sequential ESWL was done, and then stone retrieval was done by the ERCP. And surgical interventions, I am not going into the detail of surgical interventions, as most commonly used was a modified Pustow procedure, Beggar procedure and Frey procedure. Those procedures are actually what they are aiming at is a pancreatico-jejunostomy to decompress the pancreatic duct, and also jejuno-jejunostomy can be done. So this total pancreatectomy and islet cell transplant is gaining more popularity for the past few decades. Mostly it will be more useful in children with severe refractory chronic pancreatitis, and studies have shown there is a high rate of pain relief and also high rate of insulin independence. So this is one study which followed it's a retrospective study which followed 75 children who underwent a total islet cell transplant, and what they found was nearly 90% reduction in the pain severity, and 90% of them are off narcotics. Interestingly, they found 42% were achieved complete insulin independence. So those are all the treatment options for children with chronic pancreatitis. This is the final algorithm summarizing the management of chronic pancreatitis in children. You have a history consistent with chronic pancreatitis. Go for evaluating the risk factors, do the test for risk factors, and do the test for to find out endocrine or exocrine insufficiency, and consider genetic testing. MRCP plays a major role, and if MRCP is inconclusive, you can use EUS as a diagnostic tool, and if MRCP and EUS showing more of like a pancreatic divisum, and also some pancreatic stones or strictures. And in symptomatic patients, you go for a therapeutic ERCP. Therapeutic ERCP is useful in doing sphincterotomy, stone extraction, and stent placement. With that, you further decide whether to go for a surgical procedure or not. And ongoing medical care is very, very important. You should continue the medical care throughout your treatment. So in conclusion, CP in children has variety of causes. However, genetics and structural causes plays a major role. Multidisciplinary approach is very important for optimal care of these children. And adequate analgesia, adequate nutrition, enzyme supplementation, and insulin as necessary is the mainstay of medical management. US ERCP should be used judiciously. It's a beautiful, they are all very important therapeutic measures, but you have to selection of patients is very important to get the maximum benefit of these procedures. And decompression of the pancreatic duct can be achieved either by endoscopically or by surgically. And children with refractory chronic pancreatitis who have symptoms and complications, we should try surgical management or islet cell transplant. Thank you.